and we'll get going. Okay, so first things first, I'm just gonna blow this up a little bit. My computer has been freezing a little bit today again, but I'm gonna try to keep it, you just might have to wait a second between things, yeah, see. So, but once it unfreezes, you'll be able to see everything. There we go. Okay, so let's start with this whole concept of blood pressure and what it is. Most of you already know this stuff, but we're going to go through it because you want to be able to recognize the answers on the test and be able to recognize it the way kind of it's being explained through the textbook. So blood pressure, when you see it like this, is the pressure being exerted against the blood vessel walls, pretty much by the blood. Okay, there are some other factors, but it's really the pressure that's being placed against the blood pressure walls. And if you look down here, this is how we normally see blood pressure. So you know that the top number here is the pressure during systole, and the bottom number is the pressure during diastole. So I drew a nice little picture. Well, I didn't draw them, but I pasted them in. Top number, you can see that this is the heart contracting or during systole, and the bottom one is the heart relaxing and filling back up, and that in diastole. Okay, I know those are basics, but it's good to have. So what is it that kind of determines, or what kinds of things affect blood pressure? So really these two concepts of a cardiac output and systemic vascular resistance, they're also made up of other things, right? But sorry, I gotta check that. Okay, so they're also made up kind of other things. So this cardiac output here, sorry, this is the kind of the amount or the volume of blood that's ejected from the heart over 1 minute. Okay, that's always going to be cardiac output. That's always what cardiac output is. How do you calculate that? What we do is we take the stroke volume, and the stroke volume is the amount of blood that's being ejected with each contraction or each stroke. So we would take that and we would multiply that by however many beats you have in a minute. Hopefully that makes sense. So we're taking the amount that's going out in each stroke, multiplying that by however many strokes or beats we have in a minute, and that gives us a number, cardiac output, and it's liters per minute. That doesn't not really matter for this. And then we have this systemic vascular resistance. This is how we, or the name kind of that we use to describe the force that's working against basically against blood flow. So it can be created, yes, and mostly by the blood vessel size. So whether it's dilated or constricted, or blood viscosity. Those are two huge kind of things that will affect SVR, or systemic vascular resistance. And those things will kind of, it makes sense, right? These are the things that work against the flow of blood. The thicker the blood is, the less easy it's going to flow. The blood vessel, and just in case, I know you guys know this, but when the vessels contract, it makes the space inside the lumen thinner, smaller, and that creates higher pressure. When it dilates, it makes the lumen larger, and that gives you lower pressure. It relaxes, so you have less pressure. Now, I think she kind of, well, let's go this way. So nothing in there is confusing, right? Like everything there, before I move on, everything there makes sense, right? Let me know if you have any confusion about that, because once we get going, it'll be hard to go back. All right. So how does the body regulate all of these things? So there was a lot of, like, in the slides, it kind of went barrel reflex, and then I don't know, I kind of organized them over here because I like to have things, I don't know, just written out very clear for me. Even these visuals are a little bit not my thing. But anyway, you have these ways that the body regulates blood pressure, okay? These three ways, these first ones, the baroreflex, the sympathetic nervous system, and the vascular endothelium, are things that happen fairly quickly in terms of when something happens to the body, or when we need the blood pressure to go up or we need it to go down. These three things happen very, very quickly. The more longer term things that help regulation are the kidneys and hormones, one of which comes from the kidneys anyway, so it's a lot of it really is kidney. But these are the things that we're going through, okay? These are the ways the body regulates blood pressure. They kind of interchange, so kind of like intermingle. Let's go through them. So we'll start with the baroreceptors, okay? So inside if you just look over here, inside the aorta, the aortic arch, and the carotid arteries, you have these little things, these nerve endings. They're called baroreceptors. They are very, very sensitive to pressure and touch. And what that means is they can feel the pressure dropping or increasing. They're very, very sensitive to that stretching. If the blood vessel fills, or if it's full and it stretches, immediately they know, okay, we've got a high blood pressure. They send that signal off, right? If the blood vessel is not stretching, they can feel that. It's almost like they can touch the blood. So the book literally said they're sensitive to pressure and touch. I like thinking of it as like that stretch, because touch is a little bit weird for me, but either way, they're sensitive to whatever pressure is going on in there. The carotid artery, the receptors in here are quite a bit more sensitive than the ones in the aorta, and they actually move a little bit quicker. So let's say if you look here, and I'm going to give this to you guys, but if you look here, you'll see a decrease. If we start with the decrease in arterial blood pressure, and it's written in yellow, so just follow the yellow all the way around. If you want to see what happens with increase in blood pressure, then follow the green all the way around. Okay, we'll start with the yellow, just for the sake of it. So the blood pressure is low. Those baroreceptors immediately sense that through their pressure and touch. They feel it. It's a decrease of stress. So they're going to slow down firing off their message to the brain. If the arterial blood pressure is high, it's going to feel that stretch through pressure and touch, and it's going to stimulate the baroreceptors to fire more. And so these baroreceptors, again, remember they're here and here. They're going to fire off whatever their message, if you want to think of it that way, to the vasomotor center in the brain. And this got a little bit confusing because it is the vasomotor center where it's located and what it does. You have to recognize that it actually is a part of the sympathetic nervous system. It's not just like on its own, okay? The part of the body that regulates our heartbeats, where it is, right in the medulla and pons, it is part of the sympathetic nervous system as well. But this immediate action that goes very, very quickly through the baroreceptors is like its own separate just pathway, right? So we've gotten the message to the brain immediately. Whether the pressure is up or down, it will react. So if the pressure is down, we started with down, right? It's going to constrict the blood vessels, right, to try to create higher pressure. It's going to increase the heart rate and contractility, right, because we want to increase pressure. And it's going to increase the venous return to the heart. Same thing. You don't need to memorize like this kind of stuff. Just understand like this is what the body, understand how the body is going to create more pressure or create less pressure. You guys know vasoconstriction creates more pressure. You know that if you pump more blood faster, it's going to create more pressure. It's very logical. You don't need to go crazy like trying to memorize, these 3 points exactly. And then if the blood pressure has been high and the baroreceptors sense that, they sent the message to the brain, came back, and they now will do the opposite, right? They will slow down the heart rate, slow down contractility, which means it's not going to pump as hard. It's not going to pump as fast. And then the dilation, it will dilate the peripheral vessels. Yeah, we're not there yet, but yes, we will go over that actually right about now. So that right there, what I just talked about, that is when we talk about a baroreflex or the baroreceptors, that is your baroreflex. That's it. That's the whole pathway, okay? So if you can understand that so far, you're good to go. So we're going to talk about that sympathetic nervous system pathway now. So again, you've got a drop in BP, right? Let's say a drop in BP. Again, the body will recognize this and immediately sends a signal to the sympathetic nervous system, right? And the sympathetic nervous system is going to do its regular thing, right? And this is where you were wondering, right? So the sympathetic nervous system uses epinephrine and norepinephrine, okay? When you see, sorry, my computer froze. When you see acetylcholine, we're talking about the parasympathetic nervous system. So that's why we call it a cholinergic. That's why we use anticholinergic medications, right? We'll go through that in another unit. Right now we're talking about the sympathetic nervous system and what it does. The first thing we're going to talk, because the norepinephrine is what's really important here. But just so you know, the epinephrine is going to cause vasodilation and dilation of the muscles, in like the blood vessels that are in your muscles. This is because your SNS response is that fight or flight response. When that gets kicked up into gear, that's your body thinking you have to run from something, right? It's scared. It's giving you that ability to fight. And so it puts a lot of, shunts a lot of your energy or what have you, opens up the blood vessels in your muscles. And then it does this bronchodilation. That's why we give epi when people are having a hard time breathing, right? So enough of that. So your norepinephrine. What it mainly does, we'll go this way first, is it's going to have an effect on the beta receptors in the heart. So these beta 1 and beta 2 receptors are in the heart. They're located in the heart muscle, in the myocardium, and also in the SA node itself. The SA node, in case you aren't aware, is the where your contractions of the depolarization and repolarization of your heart begins in order to contract, right? We won't go through all that, but that's where the beta receptors are. And so this sympathetic nervous system, when it's triggered, the norepinephrine will trigger these beta receptors. You can learn these words if you want. Chronotropic, meaning we increase the heart rate. Inotropic, meaning increase contractility. Dromotropic, increase conduction speed. But really, the bottom line is understanding that norepinephrine is going to trigger those receptors or hit those receptors in a way that makes the heart rate increase, makes the heart contract stronger, makes the contraction, the actual movement stronger, and then speeds up the conduction of the heart. So what you're having there is an immediate response in the heart. Okay, this because it's beta 2 in the heart, beta 1 and 2, in the heart. That's where they're working. But if that was the only thing, we would just kind of have, your heart rate going up, your contractility going up, and your conduction speed going up, which is great. but it does a couple of other things as well. So when you're, again, your sympathetic nervous system is triggered, it's done that, what we just talked about. It also sends a signal or what have you to the A1 receptors in your peripheral vessels, meaning the blood vessels in your legs and hands and feet, your body, not necessarily your arteries. And it causes vasoconstriction in those muscles. Okay, so again, A1 is vasoconstriction or vasodilation, I guess, in the peripheral vessels, and beta 2, 1 and 2 is all about the heart. Betas 1 and 2 are those nodes that are, they're on the heart, receptors that are on the heart, and they're all about changing the heart rate, contractility, and what have you. So that whole thing right there, there's another kind of little piece of it, but that's pretty much your sympathetic nervous system response, okay? It kind of blurs into one of the longer term responses though, because one of the other things when your sympathetic nervous system is notified of a drop in blood pressure, one of the other things it does is it immediately, so you can see here, this is the beta 1 and 2, this is the A1. This is the other thing that it does. It triggers the kidney to release renin. And renin is an enzyme that is basically created in the kidney. And it works in this whole, it triggers this whole renin angiotensin, aldosterone system. This is where I think people get stuck a little bit, but it's actually really easy. Hopefully you'll be able to kind of picture this in your head when you do the exam. But once this renin is triggered, what it does is it's an enzyme again, right? So it's going to play a role in changing something. So actually what it does is it changes angiotensinogen, which again is just a protein or whatever that's already in your body, changes that into angiotensin 1. So great, now we've got angiotensin 1. This is where our angiotensin converting enzyme, or ACE, that is where that comes into play. And it takes angiotensin 1 and turns it into angiotensin 2. And we know from all of our time nursing and what have you that what angiotensin 2 does. One of the major things it does is it causes vasoconstriction. Immediately on its own causes that vasoconstriction. Okay. It also stimulates the release of aldosterone. And remember, aldosterone is excreted from the adrenal cortex. That's why I have these dotted arrows here, because it's back at the kidney, right, where the adrenal gland is. But it's stimulating the aldosterone secretion. Aldosterone is all about increasing the amount of sodium and water that the body is retaining. So aldosterone is going to make the kidneys retain or reabsorb more sodium and water than they normally would. This comes into play, this whole concept, guys, this whole renin angiotensin thing is huge for the NCLEX. It comes into play like in a million different kind of little pathways and stuff. For this test, this is all you really need to understand. What I've put here, you don't have to go much deeper. The only other thing it does is it stimulates angiotensin 2. It stimulates antidiuretic hormone, or ADH. That is in the pituitary. It stimulates the pituitary to release that as well. And if you look at it, antidiuretic, right? We know what diuretics are and what they do. And we're releasing a hormone that does the opposite. So it's doing basically the same thing that this aldosterone is doing. It's reabsorbing as much water and sodium as we can. And Why? Because we've triggered over here, we've triggered the sympathetic nervous system that we have a low blood pressure. So it's started the heart beating really quickly. It's got your peripheral vessels being constricted, and then it shot some signal to the kidneys. And now we've got, if you follow all the way through, you've got this vasoconstriction, and you've got more fluid and sodium being taken up by the kidneys instead of being excreted by the bodies, and that's all going to increase your extracellular fluid volume, which is going to increase your blood pressure. So when you look at what these things are doing, you should be able to kind of think in your head, what's it doing to basically to either my cardiac output or my systemic vascular resistance. So when you look at what the sympathetic nervous system does to the beta receptors in the heart, you know, does that affect cardiac output, or does it affect systemic vascular resistance, or does it affect both? So in this case, yes, actually, in this case, it really, most of its influence for the beta receptors is on the heart. It's on the cardiac output, really, because it's only making the heart beat harder, giving it increased heart rate and an increase in conduction speed. But you're on the right track, because if you look at that whole path, that whole other path we followed down here, it is going to be both, right? As soon as you increase that extracellular fluid volume, you're going to, of course, that's going to affect how much, you know, cardiac output, right? It's going to affect how much blood is pumping out of the heart, but it's also going to affect your systemic vascular resistance, or the pressure that's working against the blood, because you have so much because you, first of all, because you have this vasoconstriction happening, right? But you also have an increase in blood volume. So that's going to affect both of those things. This is not like, I promise you guys, when you go to take the test, it's not about, you know, knowing this whole thing by heart. It's about just basically understanding what I just said. And yes, of course, you know, try to remember what the beta receptors do as opposed to what the alpha receptors do. Definitely you want to understand this renin, angiotensin, aldosterone system, and that, yes, it is how it's going to affect the cardiac output and systemic vascular resistance, because those are really the things that ultimately are going to affect overall the blood pressure, right? And so remember, we were over here, we said we're going to talk about these things. So we talked about the barrel reflex, we talked about the sympathetic nervous system in the short term, and then we talked about kind of what it does in the long term. The kidneys, the RAAS, but also those two hormones we just talked about, the aldosterone and ADH. So the only one we have to talk about that's left is this vascular endothelium. So this is actually not as complicated as I think sometimes it comes across or looks at first glance. All you need to remember about the vascular endothelium is that what's in there, what's kind of involved in the lining of the vessels. Remember, we talked about nitric oxide during inflammation and what it does. We talked about how it's a vasodilator, or it basically maintains arterial tone at rest, meaning when it's dilated, we can maintain that kind of dilation or that tone of the wall. And then your other player, really, honestly, you guys, I wouldn't worry about these. I know that's crazy, but trust me. They're vasodilators, right? But these are the main players here. And then the endothelin, and endothelin 1. Endothelin is what we're concerned with because it's the very potent vasoconstrictor. This is what's going to, If it constricts our vessels, they can get through. It's going to increase systemic vascular resistance, and then it's going to increase blood pressure, right? In terms of neutrophil aggregate or adhesion and aggregation and smooth muscle growth, this isn't anything that you need to focus on for this unit. It's really just about understanding these little, I don't know if they're like hormones or proteins or acids or whatever they are. Oh, it's an amino acid. It is an amino acid. Sorry. That this one here, endothelin, is going to cause vasoconstriction, that your nitric oxide causes vasodilation, and that, I shouldn't have crossed that out, but the EDH factor and the prostaglandin or whatever creates vasodilation. You're going to be totally fine if you just kind of keep those in the back of your mind. You don't have to, again, go crazy memorizing them. Before we move on, actually, you know what? Let me do preload and afterload, and then we can go back, because that's kind of the last of the patho, and then we can talk about what you need to study for like the other little parts. This preload and afterload, I find, can be a little bit tricky for people. So let's just define them really, really easily. When somebody is talking about preload, they're talking about basically about the amount of blood that is in the heart just before it contracts. People also call this the end diastolic volume, because it's at the end of diastole, the volume at the end of diastole. So the heart has relaxed, it has filled with blood. The second before it contracts, what is in there, that is your preload. Your afterload, think of it as, especially for this unit, it's so helpful to think of it as basically your systemic vascular resistance. It's the resistance your heart is working against to eject that blood. So your preload is all in here, it's all full, ready to go. And then we're going to eject, so let's just say out of the left ventricle, we're going to eject. But if we've got up here, this is where we're ejecting. If we have really, really, really tiny, all our arteries are constricted, for example, then our afterload, the pressure on the outside, is going to be really, really high, and it's going to be hard for the body. It's got to work against that in order to kind of to push out the blood. Okay, so if you kind of think of it, afterload, as really, really similar basically to your systemic vascular resistance, it's what the heart is working against. So we have to be cognizant of, when we're raising the SVR, what that does to kind of the outside pressure that the heart is going to work against. It's really just creating more pressure. But it also creates more work for the heart. And we'll talk about later about left ventricular hypertrophy and how this increase of workload, where the heart muscle has to work against all of this systemic vascular resistance in the afterload. The heart muscle is working so hard on that. It eventually kind of gets thick and hard, and we'll talk more about it in a bit. But that's kind of all. That's pretty much all of the patho, like the behind the scenes. This is what's happening, for each step or whatever. Before I go on and I want to give you guys some, not hints, but just want to go through and make sure you know the important parts of like this kind of stuff. Before I do that, do you guys have any questions about the patho? About any one of these kind of systems? Or they're really feedback systems, right? So if you have any questions about the feedback systems, I did just type it into the chat. I'm just going to point this out really quickly. Remember we talked about the baroreceptors, how they sense that high arterial pressure, right? Through pressure and touch, they sense it, and then they shoot that message to the vasomotor center in the brain. Eventually, if this blood pressure, the arterial pressure, is high all the time, or if it's high for prolonged amounts of time, those baroreceptors will actually reset. So they increase the threshold for when they get triggered, right? So before the pressure was at, I don't know, whatever, 70 millimeters of mercury, and they would kick in at 70, now they're kicking in at 80, right? So you're allowing that blood pressure to be high as though it's normal, right? And all of your systemic and peripheral blood pressure will be high and won't be triggering the body to bring it back down. Okay, any questions about any of that? I don't see any questions in the chat, so I'm just gonna keep going. Hopefully you guys you're getting that. Again, don't go crazy. If you understand what I'm saying to you, and yes, you are gonna have to memorize certain words and certain, but if you can understand what we just went through, you're like 3/4 of the way to passing with no problem. So we changed these little lines last year. So what is hypertension, right? It's a sustained blood pressure of 140 systolic or 90 diastolic, right? So it's not like, oh, somebody comes in and they have a blood pressure of 160 over 100 or something. It's when that blood pressure is sustained, like that's always their blood pressure. If they're coming in and they have white coat syndrome, or they're in the middle of something, their blood pressure is going to be high, right? But we're talking about when they go to the doctor's office and every time they check it, it's in like the 140s, 150s. That's going to be your high blood pressure. So the 130, the way they used to have it was that this was like pre-hypertension, but I guess technically now it's hypertension. Just, I guess they're switching them into phase 1 or stage 1 and stage 2. So if you get a question on the exam that is specifically asking you, like, when your patient has a blood pressure of 132 over whatever, technically that is high blood pressure now. They just changed the regulations in Canada. So anything over 130 is considered high blood pressure. Always look at the diastolic too, because you might have a fairly normal systolic or a slightly high systolic, but then your diastolic is super duper high. That's terrible. Like, it's terrible, right? And you can walk that through. I won't go through it with you, but and then how do you know if a person is in a hypertensive crisis? This is more, I don't care about sustained. If somebody comes into the ER and their blood pressure is 180 over 120, we're going to do something right away. So again, it's really higher than 180 or your diastolic higher than 120. To be honest, anytime we see a diastolic in the triple digits, like in 100, we're immediately concerned and we'll be kind of keeping an eye on that. Sorry if you can hear that. But really the takeaway from this, 130 is hypertension now. Let's move down. So they have these like classifications, right? You've got your primary high blood pressure and your secondary high blood pressure. In terms of the high primary blood pressure, high blood pressure, that's pretty much what everybody has. This 90 to 95% of people have this primary or essential hypertension, where the etiology is really unknown. We'll go through a little bit of that in a minute. And then this secondary hypertension here, this is a much smaller group of people, and it is hypertension that is caused by something else that's going on in the body, and that something else can be identified and corrected. So it's literally being caused by renal disease. And when we take care of that renal disease, the high blood pressure comes down, right? You guys know from experience that most of your blood pressure is just, they just have high blood pressure on their own. And I'll go through those causative theories in a second, because there is a third kind of category, and this is your isolated systolic hypertension, where only the systolic is increased and the diastolic is relatively normal. So that will increase your pulse pressure. And if you remember, your pulse pressure is just the amount pressure between your systolic and your diastolic. So if your systolic keeps going up and your diastolic stays the same, then your pulse pressure is going to get larger, right? This does, it gives you an increased risk for cardiovascular disease and target organ damage. If you think about it, what it's telling you is that the pressure is really, really high during systole. So the heart's contracting and pushing a ton of blood with a ton of pressure. Then it's relaxing to the point where the difference between that relaxation stage and that super, super contracted stage is it's so much that you're going to get more damage to like shearing damage kind of and other damage on the blood vessels as the blood's just being pushed out so quickly, right? So that's why kind of this isolated systolic is a little bit of a worry. Not that this one isn't, but so let's talk about primary or essential. There's a lot of theories about like what causes it, whether people are genetically predisposed to it, whether, you know, sodium and water retention. To me, this is a lot of that is related to renal disease, right? But maybe it's because your renin, angiotensin, aldosterone system is messed up, just like idiopathically, it's just messed up. And so it's increasing your sodium and water. So, right, you have a very high stress. If you think about that, if you're having high stress, your system, sympathetic nervous system is going to be kicked in a lot. It's going to be kicked into high gear all the time. And we talked about what that does, right? It's going to cause the beta receptors, you're going to contract, it's going to cause all of that whole kind of cascade or pathway we looked at can be kicked in just by living in constant stress, right? None of these are, you know, these are, again, they're all theories. Nobody really is 100% sure what causes just that basic, where the etiology is unknown, primary hypertension. So your risk factors, these are things you guys all know. You've heard of them a million times. The only things I wanted to, okay, so we've talked, oh, maybe it was the other group. I've told the other group this. So on an exam, whenever you see alcohol intake or cigarette smoking, if you have like a select all that apply that's asking you, you know, what are risk factors for something, it's like always alcohol and smoking. It's a high risk factor for almost every single, in fact, I can't even really think of one that alcohol and cigarette smoking do not make worse. So just click them, right? It's not, don't think too hard over that. I don't think I had anything like that on the NCLEX, but I do know that in school, those select all that applies come up a lot, and don't waste your time thinking about simple things like this. You know, alcohol and cigarette smoking is bad, right? It's gonna make all of that stuff worse. You know, diabetes, hyperlipidemia. In terms of gender, in the younger years, between 20 and 50, it's more likely that men will have hypertension, but as they get older, like over 55, it's more likely that women will have hypertension. This probably has to do with like hormone changes. I don't know exactly, but this is just something to remember. It's not, we don't need to go into like all the patho behind it. Family history, of course. Obesity, of course. Again, that's another one. Just click it. Sedentary lifestyle, of course. Ethnicity, so people of Black or South Asian heritage are much more likely to have an increase in blood pressure, like an idiopathic hypertension, and of course a high sodium intake, because we know that water follows sodium, right? So if we have a lot of sodium, then we're going to have a lot of reuptake of fluids or water into our system as well. In terms of age, so age is one of those things where there are some diseases where you do not want to click that button because, for example, was it you guys that did osteoarthritis last week? I think so. Like, that's not a normal part of aging, osteoarthritis. However, it's not necessarily a normal part of aging in hypertension either, but What is normal is that as you age, the older you get, you lose elasticity. You get less and less elasticity in your blood vessels. And so they're not able to move from dilate to constrict, dilate to constrict very, very well. And they stay in a more stiff, kind of constricted place because of that loss of elasticity. And they don't, that increase obviously is going to increase your blood pressure, right? So then if you want to look at secondary hypertension, there's all of these things make tons of sense if you kind of look through them, but it's really just giving you an idea of what are the things that could cause. This is not a list to memorize. It's giving you so that you can look at it and go, renal disease, okay, how would that cause high blood pressure? I did it here. Like I was like Cushing's and hyperaldosteronism. Well, Cushing's is high levels of cortisol. Cortisol is what triggers your sympathetic nervous system to kick into high gear, right? So if we have high levels of cortisol, we have high sympathetic nervous system, we're going to have high aldosterone and all of those other things we talked about earlier, and high blood pressure. It's just really like, whoops, I look at these kind of lists as kind of little tests for my knowledge. Like, can I look at them and just go, okay, for like my critical thinking, like, how does that make sense? Okay, yeah. But I wouldn't go through and try to memorize all of these, just understand. And yes, in this case, as with every other secondary disease, the treatment is aimed at the underlying cause, what it is that's causing the hypertension, not the hypertension itself, although we will still want to lower the blood pressure, while we're doing that. And we'll talk about a hypertensive crisis in a second, or urgency in a second. Sorry. So we talked about, okay, what are these things, these two major things that are affecting blood pressure, the cardiac output and the systemic vascular resistance. And remember, the cardiac output is the amount of blood that's coming out in a minute. This is the pressure that's working against the blood moving in the veins. So these are good things to think about based on the patho that we just went through. So why does hypervolemia cause an increase in cardiac output, right? Why would renal stenosis cause affect cardiac output? Why would hyperaldosteronism affect cardiac output? And so on and so on. You would understand hypersecretion of ADH, right? That's going to cause you to retain a lot of fluids. And kind of all of these here are kind of under this hypervolemia. So that's kind of a clue as to how they're increasing cardiac output. Stress we talked about. Pheochromocytoma is, I believe, a tumor on the adrenal gland. So that will, yes, increase catecholamines because it sets off this whole process. You don't need to know that. Again, they're trying to give you like ways to think through it. You guys will get really, really used to being able to recognize what's going to show up on a test and what isn't. But I wouldn't personally worry about like, pheochromocytoma at this point. Some of these other things you need to understand for sure. And then, so when we look at systemic vascular resistance, what are the things that are causing like an increase in that, right? And so sometimes we don't know. It's just idiopathic, kind of like we talked about earlier. Stress we talked about with your sympathetic nervous system. Atherosclerosis, we're going to talk more about next week, but of course that's going to create smaller vessels and increase the resistance. Renal artery disease, again, because we're ending up with that increase in angiotensin 2. And again, angiotensin 2, its number one thing that it does immediately right away is vasoconstriction. It's going to constrict those blood vessels right away. Then it's going to do the whole aldosterone and ADH thing as well. Again, with the pheochromocytoma, thyroid dysfunction, diabetes, these are all kind of obvious like ways that it's messing with your entire body's kind of metabolic system. Cerebral ischemia, I don't know if you remember the Cushing's triad, but I wouldn't necessarily memorize why this is all happening, but have an idea that these are some of the things that can cause systemic vascular resistance. Okay, so we'll talk about a hypertensive crisis and how we can treat that. So this is really, like, before I started working in the ER, I never really thought of hypertension. Like, you think of hypertension as something that's like a long-term thing, but when you get someone that comes in and their blood pressure is like 200 over 120 or something, you realize really fast how serious that is and how serious it can be. So hypertensive crisis is a severe sudden increase in your blood pressure, but always with your diastolic blood pressure high. Like, your diastolic blood pressure will be 120 is a bit high, but for textbook purposes, 120 millimeters of mercury. Okay, that's how they kind of decide this is a hypertensive crisis. It went up very severely, very abruptly, and it's up. The diastolic is above 120. What's really important here is how fast it went up. Not necessarily like I was sitting at home and all of a sudden I felt terrible, like it went up within a few hours and you come to emerge, right? That's what's telling us that it's something more than just kind of long-term hypertension. I'm not sure where, so you have an increase, right? So you've got an increase in blood pressure. It's kind of its own little like vicious cycle. This isn't that important. I just kind of went through it myself, but you can see what happens is that increased blood pressure is causing further endothelial damage, which is causing further vasoconstriction, which is causing worse blood pressure, which is causing, right? It just goes around and around until eventually you have damage to one of your target organs, one of those major organs. And we'll talk about that in a minute. What can cause a hypertensive crisis? Oftentimes when I've seen it, it's been people who are diagnosed with hypertension and have not been taking their medication for however long. And then suddenly it's just so high. So I would say like medication non-compliance. It's not that I haven't seen people, amphetamines and cocaine and stuff, absolutely. But at that point, there are different things to worry about as well. But here, this is like, let's get this hypertension down right now. Yes, it's classified by degree of organ damage, just meaning that like, how bad is the hypertensive crisis? Well, it has to do with how has it affected the heart or the brain or anything else in the body, your kidneys or what have you. If it hasn't really had a huge effect on those yet, we're of course we're taking it seriously, but it's not as serious as, when it all of a sudden you've got somebody comes in and you do an echo and their left ventricle is like super thick and barely pumping because they've been in a hypertensive crisis for however long, right? So hypertensive crisis is kind of it kind of splits into two categories. So hypertensive emergency and hypertensive urgency are both types of a hypertensive crisis. They're just kind of like one's worse than the other, right? The big difference between them, so a hypertensive emergency, you're going to see evidence of target organ damage. In other words, you're going to see something that you're going to see pulmonary edema or unstable angina or dyspnea or something outside of just the blood pressure that has gone off, right? Whereas hypertensive urgency, you won't see that clinical evidence of that target organ damage. It's really the big difference between those two. Yes, hypertensive emergency develops over hours and days. It's much more serious. It's a very severe bump. But the issue here is this target organ damage. Here it develops a little bit slower, still a severe bump, but no target organ damage. Big difference, just in terms of how it's affecting everything. So over here, we just have some of the possible, don't worry, you do not have to memorize all of this. It's just some of the possible kind of ways that those target organs can be damaged, or ways that you will see that damage from the hypertension, right? So usually hypertension has on its own, not really as a crisis, but just on its own, you don't see a lot of symptoms, right? It's kind of silent. It's pretty much asymptomatic on its own. It's only when it becomes severe, and usually that does involve a hypertensive crisis, but where you start to see symptoms that are related to target organ diseases. That's where you'll see the manifestations. On its own, you may sometimes experience fatigue and dizziness, but most people don't even know they have high blood pressure until it's already affected some part of their body, unless they're like my dad, who's obsessed with going to the drugstore and measuring his blood pressure every day just for fun. Otherwise, you might not even know you have it. So this is why, part of the reason why you guys, I'm sure all of you, especially people in nurses' offices or doctors' offices, why you're checking blood pressure just constantly, right? So when it does cause end organ damage, I'm going to pull out of these examples here, the ones that I think you should remember that are important. I don't want you to try to memorize these lists, okay? I put them in here because I think that they help you understand. So what kinds of things are you going to see with the heart? You have hypertension. Really, you will see the heart sometimes, especially in a very severe hypertensive crisis, you will see decompensation so quickly. Patient will often go into heart failure very quickly. And heart failure will result a lot of the times in pulmonary edema, right? So you'll see things like chest pain, whether it's stable or unstable. You might see an MI, dyspnea. This left ventricular hypertrophy we kind of talked about already. This is more a result of its end organ damage. It's like target organ damage, but it's more a result of a long-term hypertension that's really not treated or not treated well enough. So you have a sustained blood pressure and a sustained systemic vascular resistance, right? And like I said, when that vascular resistance is pushing against, I'm just going to kind of pushing against that flow, right? It makes the heart muscles have to work twice, 3 times, however much, harder than they would normally. They have to push so hard. And what happens is the myocardium around that left ventricle, it gets really, really thick, and kind of like doesn't lose its elasticity, but it's kind of stiff. It doesn't contract as well anymore, which seems kind of like counterintuitive, right? Because the muscle's bigger, but it doesn't. It's stiff, right, and thick. You see how thick there's not as much room in here for the blood to fill up. So a left ventricular hypertrophy, you'll see on scans, you'll have like your ejection, like what's coming out of the heart will be fairly low, because first of all, there's not as much space in the ventricle anymore, but also the heart can't pump as hard anymore, right? This is where you get people on like meds that increase the contractility, but you don't need to worry about that. So that's really for the heart. Those are all the like important kind of side effects or damage to the target. The big ones for the brain are your vascular issues like stroke, TIA, hemorrhage, right? And that's obvious. We've talked about how, I don't know if you guys have covered stroke yet, but you will. Talked about how that pressure plays a role in causing clots and what have you. We'll talk more about it next week. Sure, you may have headache if you have an increase in intracranial pressure. Not as much. We see a lot more of like cardiac symptoms from high blood pressure, but not to say that we don't see a lot of strokes. I guess maybe more vascular is what I'm thinking. Peripheral vascular disease, sure. I wouldn't worry about remembering an aortic dissection. Renal insufficiency. I mean, yes, it's going to affect your kidneys. That's another maybe important one that I would try to remember. That, and you can understand why, right? You've got all that increase in pressure and all that increase in what's going through the kidneys and being filtered in the kidneys, and it damages the nephrons. There's stuff with eyes. It's really interesting that this is one of the more common kind of target organ issue with long-term hypertension. This damage to the retina and really just like it's hypertensive retinopathy. So problems with the eyes. That's all you need to know. You don't need to like memorize all of these things. Just know that that's a big indicator. So really quickly, how do we treat? So I want to make sure we get up to those meds before we go because they're really important. So I'll stick around. I'm going to stick around and finish this. It's 7:30 now. Technically, we're only supposed to be here for an hour. If you have to cut out, go ahead. The video, I'll try to post the recording before tomorrow. Otherwise, if you can stick around, it'll be good because we need to get up to those meds. So nursing management, hypertensive crisis. We're not worried as much about the increase or the hypertension as we are about the target organ and the increase, right? Somebody comes in with increase in blood pressure, but we can get it down and it hasn't had any end organ damage yet. We're not nearly as worried. Now, once there is some target organ damage, those patients end up in the ICU eventually on IV hypertensives like nitroprusside. Those usually will start those in the ER. You will monitor a BP very, very often when somebody comes in with something like this. So most of the time they'll have like an art line. So you'll have a constant blood pressure. If not, you would put an automatic cuff and just have it go like every 2 to 5 minutes. You just want to see that blood pressure coming up, constantly, right? And then, yes, obviously you would hook them up to telemetry. You want to watch their cardiac function. And this frequent neuro checks is important. And I'm sure all of you know how to do a GCS. The goal is to decrease your mean arterial pressure by 10 to 20% in 1 to 2 hours. If you guys remember, your mean arterial pressure is the average pressure through one cardiac cycle. So from systole, the blood is contraction, the blood's pushed out, the body relaxes all the way, the vessels relax all the way until that preload. That whole cycle, the map is the average pressure through that entire cycle. It's usually, we want it between 70 and 100, but you don't need to know those numbers. Just giving you an idea. So diagnostic test, this stuff's easy, right? History, physical exam. We're always going to do CBC and chemistry. When we do our chemistry, we're looking at sodium, potassium, creatinine, and BUN to think about why. So we know whenever we're dealing with fluid volumes, we're gonna look at our sodium, potassium. Creatinine and BUN are huge indicators of kidney damage, so we want to keep an eye on those. See if there's anything else really important here. 12-lead ECG would be done as well. We're going to monitor. Nutritional therapy is important. This is huge. Restrict sodium. When you have someone with high blood pressure, we're going to restrict sodium, and oftentimes we'll also put them on a low fluid diet. We're going to restrict cholesterol and saturated fats. This is like not just in a hypertensive crisis. This is maybe they've had the hypertensive crisis, now they're going home and they're living with chronic hypertension, or somebody who's just living with chronic hypertension, right? We want to decrease the cholesterol and saturated fats. Going to monitor potassium, but that has more to do with medications, which we'll talk about in a minute. Weight management, I would say, is like the cardinal thing that you need to worry about in terms of therapy. We want to have somebody lose weight, right? If they're overweight, it's just a huge aspect through exercise and eating well, but that's the purpose of it, right? Anti-hypertensive meds we'll talk about. It's good to know these medications that aggravate blood pressure, especially corticosteroids, which aggravate everything, it seems. So that's easy to pick up. Erythropoietin, that makes sense, right? Because you're making more red blood cells. You're making the blood more viscous. Licorice fruit is just a weird one. Other than that, and salt, of course. Other than that, I wouldn't worry too much. One more little thing, and then we'll do meds. Actually, no, this is more specific. Like, what should your BMI be? How much sodium should you have a day? How much exercise? I just know that sometimes on tests they ask really specific questions. So I pulled that out of the book for you. Okay, so let's talk about the meds, because this is really where I find on these kind of tests, like a quarter of the questions end up being med questions. So let's go through like the really important stuff. We'll start with the thiazide diuretics. Most of you have given these, the hydrochlorothiazide or indapamide. What these do is they block reabsorption of sodium and water in the kidneys. So if we block the absorption of sodium and water in the kidneys, where does the sodium and water go? It's diuresed, or it's excreted through the kidneys. When that happens, we have a lower extracellular fluid volume. And then I wrote in exactly how it affects this systemic vascular resistance and cardiac output for each of the meds. So you can see the path and why that med works for us, particularly for hypertension. Lower fluid volume means lower SVR, lower cardiac output, and it results in a lower blood pressure. Adverse effects for thiazide diuretics. Okay, for all diuretics, this is your big side effect. If any of you work on cardiac floors, or with anybody who's on loop diuretics or thiazide diuretics, you'll know that we are constantly monitoring potassium levels, and oftentimes having to give supplemental potassium to patients who are on diuretics. This is a massively important thing for life and for NCLEX. You just have to know that. It's like nursing 101, right? They can also cause hyperglycemia and a decrease in like sexual dysfunction as well. This is why some people will go off of it, just because of the sexual dysfunction. And then we want to be careful, obviously, with anyone with renal failure. So when you have a med and you're looking at it, and you can walk yourself through this part of it, then these kinds of things come a little bit easier, because you can think, if you have a question and it's giving you these options, like, what should you give your patient thiazide diuretic? What should you be worried about? Select all that apply. You know that this is what the med does. So if you have an option for hypokalemia, you can think that through, right? If you have this, particularly if you have, should I be concerned about renal failure? Should I give it to someone with renal failure? You can think it through. Well, we're getting rid of all the extracellular fluid. Where are we getting rid of it? In the kidneys. The kidney's working high gear to filter all of that medicine, or all of that out, right? Oftentimes on those cardiac floors, one of the other really important numbers is your creatinine, right? And you won't be able to give it if you have a certain level of creatinine kind of dysfunction. This direct renin inhibitor is something new. I've never seen it in life. You can understand how it works. This is a really easy one. It inhibits that release of renin. So if you look at that whole thing that I did up earlier, I put another copy of it here, and you can see exactly where each medication works. So this is where it stops this trigger of renin. Then it's going to it stops this triggering of renin right here. It's going to stop everything else after it as well, right? So we have none of this happening. So we're going to have a lower extracellular fluid volume, same as the other one. We don't know any adverse effects because it's a brand new drug. Here's a big one. So ACE inhibitors, just so you can recognize them, they end usually in IL or PRIL, ramipril, captopril, lisinopril. So what this does is it blocks that enzyme, this angiotensin converting enzyme that converts angiotensin 1 into angiotensin 2, and that means it stops that path right here. It's not going any further. It's not causing this vasoconstriction. It's not causing this aldosterone release. And so you're going to end up with less vasoconstriction and less fluid volume, and that's how it lowers your blood pressure. Now, ACE inhibitors have a number of side effects that you need to remember and we need to worry about. The first is orthostatic hypotension. This is something you need to worry about anytime you're giving a medication that's going to lower someone's blood pressure, even your diuretics. The reason it's not a huge worry in a thiazide diuretic is that it doesn't drop your blood pressure as quickly as a loop diuretic. But in an ACE inhibitor, it can drop your blood pressure enough that when your patient stands up, they drop. So you want to have them sit at the side of their bed before they get up and all those little tricks, right? One of the main side effects, and you'll see this come up on tests, is a dry cough. This is just a normal side effect, but sometimes it can get so bad that we have to take the patient off, the physician will take the patient off of the ACE inhibitor, put them on something else just because it's annoying. And then the hyperkalemia. This is really between this and the orthostatic hypotension, are the two really big things that you need to think about in terms of the ACE inhibitor. When you block that aldosterone production, right, you're decreasing that absorption of sodium and water. So that sodium and water is coming out now instead of you're decreasing the extracellular fluid volume. Then there isn't as much. So normally what the kidneys do is they reabsorb sodium and water and they flush out they flush out potassium. That's kind of their baseline move, right? So when we start to excrete that sodium, right? Think of it like this. Most of the time when your sodium goes one way, your potassium goes the other. So if your body is getting rid of all of this sodium that it doesn't normally get rid of, it's trading places because it has to trade places in the sodium potassium pump, right? It's trading places with that potassium. So that potassium is going to go up. So you might lose all that sodium, but you're going to gain potassium. So keep an eye, 100% hyperkalemia in your ACE inhibitors. I'm not going to worry about these angiotensin 2. You can read through them. It's very, very simple, does very, very similar thing, and there aren't any really serious adverse effects that I want to highlight. The only thing I think I want to highlight with the calcium channel blocker, so this blocks the calcium channel that's necessary for smooth muscle contraction. So it decreases your vasoconstriction, decreases your afterload. Keeps the heart beating really, really regularly, but it does cause bradycardia. So we would never, ever give this calcium channel blocker with a beta blocker, which we're going to talk about next, because you can actually get this like profound bradycardia, right? We don't want to give this to someone in heart failure. Again, you're slowing the heart down and decreasing the contraction of the vessels. So you have to think about what that's going to do to the rest of the body, right? Here's the big one. So your two really, really big ones, maybe three, would be your thiazide diuretics, your ACE inhibitors, and your beta blockers. You need to know those. A beta blocker is doing exactly what it sounds like it's doing. If you follow my little line here, you'll see that it's blocking those beta receptors. So that signal that's coming from the sympathetic nervous system, it can't trigger those beta receptors on the heart that make the heart go faster, make the heart contract harder, make the heart pump faster, I guess. Sorry, I already said that. But and so when you have that, you're going to decrease the cardiac output and you're going to have a lower blood pressure. So that one's like really, in terms of mechanism of action, it is exactly what it sounds like it is, a beta blocker. Again, you have to watch for hypotension. It's a big one. Bradycardia here, that's because Well, you know why, because it's slowing down the heart, right? This is why we don't take these two together. It can be just a huge, huge mess. One of the side effects of a beta blocker is a bronchospasm. I won't go into all the patho of that, just to know that we want to caution giving a beta blocker to a patient who has, say, COPD or some other breathing problem, because it does cause a bronchospasm, right? You know what, I got to go through it. Sorry, I just want to make sure you know it. So a beta blocker can kind of hide, I guess I want to say, the signs of hypoglycemia. So what are the signs of hypoglycemia are like a tremor, bradycardia, palpitations. Those things are usually caused by those epinephrine and norepinephrine, right, that are signaling they're signaling the body to react to something. And if your heart is slowing down or always staying around the same thing because you're on beta blockers, you may not notice that you are actually having a hypoglycemic reaction. You may actually miss an SNS response entirely because of this, because the body is regulating this while the beta blockers are regulating that so well. So this hypoglycemia awareness, really just remember it can mask the signs of a hypoglycemic attack. So you want to make sure you know that. And then the alpha blockers, I think I can let you guys read on your own. It's not a huge, those three are really, really the most important ones. The thiazide diuretic, the ACE inhibitor, and the beta blockers in terms of hypertension. Those are the three that I would focus on. And again, you can see how they work if you look at this, at this whole thing. You can see where they work in that whole kind of train of stuff that I showed you earlier. Before I let you guys go, sorry, I had to go so fast there because I don't want to miss anything. I want to get everything in that I can. But is there anything that you want me to clarify? Because I went really fast. Do you have any questions about anything before we go? Whew. My throat's actually sore from talking so much. No questions? Okay, good. Oh, good. I'm glad, Laura. I'm glad that it's helpful. So again, then I don't know if I'd call it life-saving, but I think you guys are gonna rock. If you, I will post this tonight, and so many thank yous. You're welcome. You can look at it tonight, tomorrow when you're studying. I will post. No, the notes are already posted. The notes I showed you earlier, those are already posted. And again, everything that's in here is in there. It's just a different way to present the information. So if you think better like I do, looking at things in an organized list, then use that. If you think better this way, then use this. Okay, I'm gonna let you guys go. I'm really hoping you guys, I'm sure you will do great on the test. And hopefully I'll see you back next week. I can see how you did. Yeah, and we'll start in on atherosclerosis. You're welcome. You guys are very welcome. I'm just going to turn the recording off.